The first case is a 25-year-old male who was admitted with clinical features of nephrotic syndrome. Quantification of the urine protein showed 10 grams proteinuria with hypoalbuminuria with normal creatinine, dyslipidemia, and bland urine sediment. There was no family history of renal disease. Renal biopsy showed light microscopy 9 glomeruli which were enlarged, hypercellular with lobar accentuation. Mesangial and endocapillary hypercellularity was present. Double contours were seen on the GBM in some areas. Immunofluorescence showed 3 plus C3 granular positivity on the capillary loops and mesangium. C3 levels were low. A diagnosis of C3 glomerulopathy was made. The electron microscopy finding is awaited. The case witness was a 32-year-old female who was evaluated for edema, who had features of nephrotic syndrome with a serum creatinine of 3.6 milligrams per deciliter, with no obvious history for the renal dysfunction. Ultrasound showed normal size kidneys, and biopsy showed 11 glomeruli, out of which 2 were globally sclerotic. The viable glomeruli were enlarged and showed mild lobular accentuation with mesangial and mild endocapillary hypercellularity. Double contours were seen on the GBM in a few areas. IFTA was there 10 to 15%. Immunofluorescence showed C3, 3 plus staining intensely positive on the capillary loops and mesangium and focally on the tubular basement membrane. For this patient, the diagnosis was membranoproliferative glomerulonephritis. The third case is a 23-year-old female, primigravida, 20 weeks pregnancy, apparently all right till 20 weeks, admitted with history of seizures. The blood pressure was 180 on 110 millimeters mercury. The investigation showed hemolytic anemia and thrombocytopenia. Her serum creatinine was 13 milligrams with significant hyperkalemia. Emergency hemodialysis was initiated with supportive management. Ultrasound showed a dead fetus and expulsion was done. Patient had clinical features of hemolytic anemia with schistocytes on peripheral smear, continued to be anuric. Renal biopsy was done once platelets improved, which showed thrombotic microangiopathy. 19 glomeruli were identified, 2 were globally sclerotic. There was endothelial swelling with acellular closure of the capillary tuft with fragmented RBCs entrapped in the arteriolar wall. There was tubular epithelial cell swelling with cytoplasmic vacuoles and patchy lymphocytic infiltration in the interstitium. Immunofluorescence was negative. Diagnosis of thrombotic microangiopathy was made. She was initiated on plasmapheresis and an empirical course of steroids were given with no response. ADAM TS13 levels were normal. Patient did not recover from the renal failure and is hemodialysis dependent on date. And she wants a renal transplant with mother willing to be the donor. So these are the 3 case scenarios which we have presented. Yes, sir.
Yeah, in your second, Dr. Kashi from Trivandrum.
Yes, sir.
In your second case, that photograph, that patient face appeared to have a lack of fat, the cheek.
Yes,
so is it a case of partial lipodystrophy associated with you?
Yes, sir. Yes, sir.
It was. That's something that you should have highlighted because a combination of partial lipodystrophy and MPGN.
Yes, sir. Yes, sir.
That face is quite characteristic of a partial lipodystrophy.
Yes, sir. Yes, sir.
Yeah.
So, do you have any questions specific to the cases, or like what are your questions, Dr. Rama?
So, in a government setup, for us to do the entire panel for atypical aHUS, and the mother wants to be the donor, sir. So for a TMA, so how do we go about? She's a young lady and wants to undergo transplant with mother as the donor.
So, see, again, I would come into the same principles of management. So, 1 is the clinical presentation, 2 is the genetics, and 3 is the proteins, just like in primary hyperoxaluria. So, first is the clinical presentation. So, this is a 23-year-old female with hemolytic uremic syndrome. There is no doubt about it. When a biopsy is not mandated because it shows schistocytes, thrombocytopenia, anemia, everything there. So, the question now is whether this is a complement mediated, which is likely because ADAM TS activity is okay, So once you say complement mediated TMA, you look into two aspects, whether it is genetics or it is antibody associated. So in a 23-year-old female, you don't look into a antibody. It is usually a entity of pediatricians. It's not, adults don't see it. I'll tell you after working on about 100 cases of pregnancy aHUS. So the next point is about the genetics. So in the genetics part, what you do is you do a two set of testing needs to be done in this case. One is MLPA, and the second one is a targeted testing for some of the genes like, C3, factor H, CFHR, factor B, DJKE. These are the genes that we usually test. Once you get, then the third is the protein testing. So the protein testing could be of two types. That is, you see for complement activations. How do you see for complement activation? You look for AH50 activity. So if the AH50 activity or C5b9. So AH50 activity is largely standardized. C5b9 is specialized. So, you need to be very careful when you do C5b9, whereas AH50 is largely standardized. So I usually follow the three principles if somebody asks me. So, clinical phenotype, genetics, and then the proteins. So whether, if somebody comes from an affordable or non-affordable setup is not a question, because I presume that most of the protein testing is unavailable in this country. So, you don't have C5b9, which is freely available, and AH50 have a restricted availability. Even in our institute, there is restricted. Sometimes they do, sometimes they do not do. With respect to the factor H antibody, I think All India Institute Delhi has a facility. Other than that, people have used commercial kits for testing, which many complement experts worldwide do not agree upon that kit. So that's how I will place it. So I think it's worthwhile to start with at least MLPA in this lady, and then go ahead like how for transplant. I would wait to hear others' comments.
In one of our cases, we could get the complement CFH antibody done from All India Institute. It is possible. They have got a scheme, and it's possible to get it done in All India Institute.
Yes, they do, sir. They do, sir. They do. Dr. Professor Baga is very helpful, and we also sent some of the cases, and he is always obliged.
And I will also share our experience on an approved atypical aHUS. The eculizumab, it just works like magic. Although it's not affordable, that time, about 4 or 5 years back, it cost about 9 rupees per dose, and we had to repeat dose on alternate days. The patient ended up spending about 9 lakhs and about 50 lakhs on eculizumab. The next day, the patient will be completely all right. And then a week later, the patient will have all the manifestations again. Ultimately, we had to send her for a liver transplant. But ultimately, she lived for about a few months after liver transplant with no renal failure, but then succumbed to complications of liver transplant and passed away.
So, sorry to interject, sir. So in the current era, I think we only look into eculizumab, and liver transplant is almost out in the Western world or in the global north. Yes, in a country like India, I think it will be an option. While we consider liver transplant, we should always be careful that there is excess bleeding during liver transplant, and bleeding. There are 3 stimulants for complement: bleeding, infection, pregnancy. So, whenever these are there, there's extreme complement. So even the liver transplant is extremely challenging, and you may require plasma exchange. So that's something that we need to know. And with respect to the comment on eculizumab, sir, the previous school of thought was, once you start a patient on eculizumab, you continue the patient indefinitely with eculizumab. Now, what we have learned, there's an article in Blood by Fadi Fakhouri where you can see that, they tried to, restrict the use of eculizumab. And what they found was only in patients who had certain CFH mutations or who have persistent elevated level of membrane attack complex, that is C5b9, these are the patients who actually recur. So otherwise, they don't do well with minimal doses. You'd be able to wean them off eculizumab therapy. So that is a new learning. And the best thing that is coming up is we've got new anti-complement therapy, anti-factor B therapy. which are coming up, and there are trials which are running in India. So, that's a good news. So I think you should go ahead with genetic testing in these patients. You may find a CFHR duplication or deletion. So that's something that we need to look at.
And just to add a point for the genetic testing, some of us, we have been asked many questions like this. So when we send an antibody testing for the CFHR, for the CFH antibody, having a positive antibody per se should not stop you from doing proceeding on for a genetic testing. Because some of these patients, the CFHR mutation is there, and sort of the antibody is against the protein, against the abnormal protein. So even if you find an antibody, do please proceed and do the genetic testing as well. That is sometimes often overlooked.
Yeah, I think, is it okay if I can make an additional comment, Sukanya? Like,
Please, sir, please.
so, it's like, 80 to 90% of the patient with anti-CFH antibody would have CFHR1-3 deletion. So, you would have a deletion in most of them. Like, so that is something that Sukanya makes a very important point. So you do an MLPA, and in the MLPA, you will find that CFHR1-3 are deleted. So the best thing with the factor H antibody is, they respond very well to plasma exchange. And once you get the antibody levels to less than, the target level, which could be less than 1,000 by what testing people do, so you can proceed with transplant. So that is something.
Sir, this is Dr. Ramachandran.
Hello.
Sir, yes.
Hello. Sir, one addition here, sir, from the genetic perspective. So most of the time, if we see the deletions, we will see the protein level goes down. But if it happens to duplications, if it happens in the in frame, we may not see the change in level of the protein. So that's why sometimes some people will have the mutation event, but they may not manifest. For some people, as per the literature also, if we see the deletion events, they are showing more manifestation of the symptoms than the duplication events. So duplication events, it depends on where it occurs, whether it's curtail the physiology of the function, or it happens in the in-frame duplication, sometimes may not alter the factor level much. So that is important, sir. But also there is a overlaying, as per the molecular underlying cause, it overlaps with T3 glomerulopathies also. Most of the times we see CFH and CFHR1-3 mutations in aHUS cases, and CFHR4-5 duplication events in C3 glomerulopathy cases. And recommended genetic testing here is always the first line workup is the MLPA workup, sir. Sequencing workup may not detect the mutations. This I would like to add from the genetic testing perspective.
I have a question for both Dr. Raja and Dr. Senthilkumar. So sometimes randomly, when you're actually not looking at, atypical aHUS or C3, you're doing a genetic test for some other reason, say for nephrotic syndrome or for FSGS or something, and then you get a CFHR1 mutation. So we know that sometimes it can be expressed in normal, it can be there in patients who do not have any disease, or it can be there in normal patients with normal phenotype and all that. So how do you go about that? Should we really go ahead and see whether there is a protein disruption there, or we can just neglect that or wait for an episode of, a TMA-like presentation to even consider that? That's my question.
Yeah, I think that's a good question. Most of the times, you find whenever you test for proteinuria conditions, what you usually find is CFHR5. CFHR5, it runs in families. It's a cause of C3 glomerulopathy, which runs in families. So you evaluate for nephrotic syndrome, and you would find that the patient has got CFHR5 mutations. So that is something we should remember. So, and with respect to finding CFHR1 or 3, I would ignore. It is not consistent with the the presentation. So I would largely.
Yeah, Raja, I have a question for you. Where I practice, we have a lot of North Indian population, especially from your part of the world, from Punjab, and we see at least 2 to 3 cases of aHUS in pregnancy. Have you noticed that it is more common in North Indians, Punjabi people, or something like that?
So I run a aHUS registry, pregnancy aHUS registry. So, we have about 150 patients of HUS. And what we found was, genetic duplications in CFHR 1 and 3 in our populations. The deletion was very less. 80% had genetic mutations, of which 70% was genetic duplication in CFHR 1 and 5. And the 10% were deletion and very rare CFH mutations. But unfortunately, I would ask the medgenome people for, we need to have the data from the healthy controls, whether the CFHR duplication naturally runs in the Indian population, and probably, the pregnancies that trigger in these kind of patients, I do not know, because we haven't tested the protein levels to really be sure of what is happening in them. I would pass on the comment to Senthil.
Yes, sir, absolutely, sir. So as per the literature also, if you see the CFHR mutations are considered as a susceptibility rather than a complete penetrant mutation, like the one we characterized for PKDs or Alport syndromes, where if you have the mutation, the patient is expected to show the manifestations. Sure, sir. Those are called as completely penetrant genes. But when it comes to the CFHR mutation, it's more of susceptibility. So some people will have the mutation, but externally it's more of multifactorial. Sometimes the very surgery, post-surgery, they are prone to manifest the symptoms. That's why it is of a concern when it comes to transplantation issues. The CFHR variants are very concerned because they may be asymptomatic, but after post-nephrectomy, they are prone to manifest the symptoms. So it is more of susceptibility, sir. And also what kind of mutations we are having, like deletions or duplication. It depends on that also. The impact of the variant and also the environment factors, the very surgery event, sometimes immunological also adds up and leads to the manifestation. It is not completely penetrant, but it's a susceptibility oriented. There is an increased risk compared to the general population. Those who are having these CFHR variants, it is an increased risk and there is a concern for the transplantation.
Thank you, Dr. Senthil. I think we'll quickly go on to next cases. Dr. Harish, simply, come to the diagnosis of, the other Alport and FSGS and ADPKD, and we'll focus on the role of genetic testing on all this with transplant in mind. I think let us not spend time on diagnosis and other areas. Harish, start. Just stop with the cases, then we'll make the panelists and the audience to comment on the role of genetic testing in deciding on feasibility or successfulness of a transplant. Yeah, quickly. Yes, Harish. Harish, you can start. Your screen is being shared.
Voice or
Your voice.
Hello, sir. Am I audible, sir?
Yes.
Audible.
Yeah.
Yes. Sir, good evening, sir. So we are presenting few case vignettes from our hospital, Tirunelveli Medical College. Here is quickly. Sorry.
Yeah. What were the cases? Alports?
ADPKD, C3.
Or I think he has difficulty getting his voice. I think instead of presenting the case, we can go straight. In a setup of ADPKD, let me start. Is there a role of genetic testing in the recipient to see, as a transplant in mind?
Anybody want to take this question or like?
Sir, good evening, sir. Now the slides are working. Extremely sorry, sir. So now, for the first case is a 43-year-old male who presented with complaints of volume overload, and we found out that the patient had the ADPKD with CUSG, which showed bilateral polycystic kidneys, and the liver showed multiple cysts, and the kidneys were enlarged. And the patient had, this is the pedigree chart of the patient, where his father and mother died at the age of 45 years and 55 years. His father died at 45 years due to a brain bleed. He doesn't know if he had a kidney disease. And he had a brother who died at 49 years of an unknown cause. He has a healthy sister, 2 healthy sisters, and 1 healthy brother. And he has 2 children. One is 20 years old and one is 18 years old. So our questions regarding this case are, if his sisters and brothers are ready to donate, how to proceed for this patient, and how to follow up his sons who are 20 and 18-year-old now respectively. And right now his renal functions are normal and his USG doesn't show any cysts. Thank you, sir.
Can you go to the pedigree part?
Let us hear some answers for these questions. Go back to the questions, Harish. Harish.
Sir, questions, sir.
Yeah, if his sisters and brothers are ready to donate, how to proceed? And how to follow up his 2 sons?
With respect to his sisters and brothers, there's a clear-cut ultrasound criteria for diagnosis of polycystic kidney disease. I think they are all old enough. So if they don't have any cyst, or you go by the definition of the ultrasound criteria, if they do not have any cyst or anything, I think they do not have polycystic kidney disease. To be honest, patients with autosomal dominant polycystic kidney disease, they have cyst right at the birth itself. Like, they say that at 15 years of age, more than 90% of them have cysts. So if they do not have a cyst at the end, at 40 or 50 years of age, so I'm sure that they do not have one. But if you want to be doubly sure, in the era of genetics where you have genetic testing facility available, so to be doubly sure, you can do a genetic testing with respect to the PKD gene and then proceed with transplant. So I think that's a way. And with respect to following his sons, I think that is important because there is a therapeutic implication. Now we very well know that certain genes are, certain genetic mutations are, at risk factor for progression. And, you give therapy while you proceed with the Mayo scoring, you do use the genetic testing as well. So that's how I see it. It's for treatment. It's for the PKD treatment rather for the
Okay. I think if there are any more suggestions on this, if there aren't any, we'll go to the next case. Harish?
Yes. So now we have a 38-year-old man presented with decreased appetite and vomiting. His creat was found to be high and he had anemia. His USG showed bilateral contracted kidneys. His electrolytes were normal and his uric acid levels were normal. He had a corneal opacity over his left eye, which he claims was there since birth. We did an ophthalmic evaluation. He didn't have any other ophthalmological problem except the corneal opacity. So this is the pedigree chart of this patient. So he had his grandfather. His father had a total of 7 siblings, out of which 5 along with him were blind. So the first 2 brothers and the next 2 sisters were blind, and followed by 2 sisters, one elder and one younger. Both are normal right now, and he is blind. So the this person's son, he presented to us with this corneal opacity and kidney disease. There is no kidney disease in the family other than his son. So this is the pedigree chart of this patient, sir. So we had a suspicion if this is a case of autosomal dominant tubular kidney disease. So how to proceed for this patient?
Anybody wants to take this question? Sukanya, you want to take this question? So whenever, like when the patient is having nephrotic syndrome or a complement mediated disease, stone disease, so you can do a targeted sequencing. Like, you're very well sure that, you would find one of these genes, that is the most common. You would have a very good penetrance. So when you do not know, I think the best way to go about is a whole exome sequencing. Where you would be able to find the the kind of where the defect which is actually hampering this in the index case. And once that is confirmed in the index case, what you could do a Sanger sequencing in his relatives and confirm the the kind of disease that they have. So this is one way of seeing it. And once you do a whole exome sequencing, again, you would like to know whether it's a pathogenic variant or likely pathogenic or a VUS. So that is something which is to be looked after doing the genetic testing. So I would certainly do a whole exome sequencing in this. And I would ask, Dr. Senthil for regarding this part of the comment.
Sir, this is Dr. Ramasubramanian, sir. Question to Dr. Senthilkumar, sir. Sir, recently there is a publication in the American Journal of Nephrology about 382 gene panel called Renal site, and there is also a mention of 177 gene panel for chronic kidney disease. Where do we stand right now in India, sir?
Yes, sir. So the literature is constantly evolving, sir. Actually, there is no clear evidence of genetics as of now in transplantation, actually. So that's being said, there are here and there some cases where they're showing evidence. As of now, as for the transplantation, the relevant genetic testing established where the case studies are available is PKD, Alport syndrome, and this one, the hemolytic uremic syndrome. For this only, there is a literature evidence I could come across. That is also I'm seeing only the post 2017 to 2022 for which. So if the recipient has the mutation in any of this, like a PKD or Alport syndrome or this hemolytic uremic syndrome, then we need to test the biological living donors. If they have the mutation, it's a contraindication for the transplantation. For other genetic mutations, it is still evolving. And as Dr. Raja clearly mentioned, there is we will get into the terrain of uncertain significance. So that is also a concern. So if we have a clear-cut pathogenic mutation identified in the recipient, then that particular mutation has to be evaluated in the living kidney donors, particularly if they are biologically related. It is very well related. If it is for PKD or Alport syndrome or is aHUS, it is more relevant, for which the literature evidence is there. For others, it is still evolving.
See, here in this patient, he has got a family history of blindness. So any patient with the chronic kidney disease, especially a syndromic type, when other organs are involved, it is better to go about genetic. Suppose if this patient is to be subjected to a genetic test, what could be this one, preferred one? Or?
Yes, sir. If it is a syndromic in nature, of course, we need to be careful because post nephrotic nephrectomy donor also it is a concern actually. If it particularly badly related, so it is a concern, sir. The genetic testing is suggested to evaluate the recipient and also in all the prospective donors if it is a syndromic case.
Yes, sir. Dr. Rajan, I mean, doing genetic test is fine. But reports telling of unknown significance, and we get more confused, more than what we were before the genetic testing in many instances. So,
that is what is the significance of the variant of unknown significance? How to interpret those reports?
Yes, sir. So variant of uncertain significance typically it needs much of time to spend on that, sir. So in the cases, if you have a clear-cut family, as you showed you one pedigree here, where a lot of affected individuals in that family. So due to genetic rarity of this kind of syndromes, not all the variants need not be reported in the literature. So the classification we are giving as likely pathogenic or pathogenic is based on the previously published literature of the similarly affected individuals. But due to genetic rarity only, we are not seeing these mutations every now and then. That N number is not there. So that's why we are classifying it as uncertain significance, but it may be of a novel clinically relevant variant running in this family. So if we could prove this case in other affected individuals in the same family, it is a good case of case publication where we can publish and establish the genetic diagnosis, and based on the literature, this variant may be upgraded to likely pathogenic or pathogenic down the years. So it is our duty to every now and then do the case publications. Or if we come across this kind of multiple family members affected, this may be as of now uncertain significance, but down 5 years, this particular same variant may be upgraded to likely pathogenic by the good case publication study. So we could publish this case actually. So we need to evaluate as Dr. Raja mentioned, we do the sample sequencing in all the family members, screen that, and see the presence or absence of this variant. And if you see that particular mutation every time only in the affected individuals and not in the asymptomatic individuals, then it is a clear case of clinical significance you can associate to the variant. It may not be, so that can be considered as a likely pathogenic. So we give the report as uncertain significance because of the lack of literature evidence, published evidence. But this may be of a novel case running in this family. So we can establish the genetic diagnosis. Right. And we can take it forward.
Thank you. Thank you. Harish, you put on the last case.
Remaining cases now.
Harish.
Sir. Yes, sir.
You finish off all the cases, sir.
And doubts so that.
Yes, sir. So this is the final case, Vignet, sir. So we had a 37-year-old female who presented with complaints of recurrent stone disease and ended up with CKD and is now on maintenance dialysis. Her imaging showed nephrocalcinosis and bilateral staghorn calculi. So we have already discussed about oxalosis before, but can the experts help us to interpret this report, which shows a pathogenic variant causative of the reported phenotype, with this report?
Pass it on to Dr. Senthil.
Sir, yes, sir. As far as this report is concerned, it's a clearly categorized pathogenic variant. That means there is a previously reported, the previous literature is available, then only we will give pathogenic. And also if you see the variant also, it is leads to termination. 444 to 458 deletion, that means the physiology of the function of the protein will be affected. It's a very established case. And as far as transplantation is concerned, for hyperoxaluria, it is not well established. I mean, the genetic diagnosis is established, but what is the concern for the transplantation in donor is not well established for hyperoxaluria cases.
So you mean we may take this case for transplant?
That's not clear, sir. It is not clear.
Living donor for transplant. I think that's what Dr. Senthil was telling.
Actually, the review of literature for transplant in hyperoxaluria says that if the already discussed, if the oxalate levels more than 20 cutoff, they are given a cutoff of 20. If it is more than 20, they say it should be a combined liver kidney. And if it is below 20, you can opt for a kidney alone. Or if there is an organ damage, there are more organs involved, then again you have to give a combined liver kidney. So the decision is based on the organ involvement and the plasma level. Of course, the genetic test is to confirm. But is there any, Dr. Senthilkumar sir, is there any possibility to tell that this patient can have a recurrence like that?
Yes, sir. So,
Karthik, the people who have risen hands, you unmute them so that they can ask their questions direct. Yeah, yes, Dr. Senthil.
Yes, sir. So as far as hyperoxaluria concerned, this is very well established gene, AGXT gene. And if there is an autosomal homozygous variant in the individual, he is going to manifest SHIRSAT. It's a very completely penetrant gene. And now this is with the affected individual perspective, recipient perspective, where the genetic diagnosis is very well established. Now, if there is a biological relevant donors, we may explore him. He may be heterozygous or homozygous for the same variant. If the biological donors are heterozygous, he may be eligible for the donor, but if he is also having the homozygous for the same variant, is also going to manifest or showing progressive in nature. So there is a concern. That is a concern for the transplant, choosing that person as a donor.
Okay. Harish, the last case.
Finish. We have only 3 cases, sir.
Okay. So, I mean, the final consensus, this case, is not, is recommended for transplant, is it?
Yeah.
He says that the donor has to be available.
Donor has to be available.
It's going to be a biological donor. Actually, this patient came for a cadaver registration. So
Yeah, liver kidney would be the best for him. Auxiliary liver, so they could split the liver into two parts, put an auxiliary liver to him and, send the main liver to somebody else.
Yes.
Oh, right.
That's
Then
what-
in cases of FSGS,
Yeah.
Is there any way of knowing they'll have early, besides the clinical markers which you have, malignant FSGS and so on, is there a way, not only in FSGS, some of the other glomerular diseases, the recurrence rate, can it be predicted by genetic tests,
So,
early recurrence?
So genetic testing is usually assuring in FSGS. So if you have a genetic testing which is positive, so you can be 100% sure that the patient would not have a recurrence of FSGS. So this is not my data, but there's an article in CJSN where they did a reverse phenotyping. And what they looked up, they looked at 265 genes, and what they found was if there is a genetic mutation and a steroid-resistant FSGS progressing to chronic kidney disease and stage kidney disease, so there would be no recurrence. So doing a genetic testing, if the genetic testing is positive, you can be assured that it wouldn't come back. To the best of knowledge, there isn't any steroid-sensitive genetic mutation, excepting for there is one paper which was reported, say about a decade ago, about EMP2, epithelial membrane protein 2. But nothing which says that any of the mutation is steroid sensitive. There could be anecdotal reports like somebody responding to ACARB, somebody responding to calcineurin inhibitor, one patient responding to steroids. So, but that they are all anecdotal. I think we should leave it over there. You will have anecdotal reports, these kind of reports there. But generally, genetics, it's a very good sign for transplant, for FSGS.
Karthik, and see, Dr. Ravi and Shakti, they have risen their hands.
Sir,
Unmute them
sorry,
so that
sir.
they can.
Sir, they can unmute themselves, sir.
Ravi, Shakti. Yeah.
Good evening, sir. I have a doubt regarding one of my patients, sir. 25-year-old boy with sudden presentation of PSRD came to me from another hospital for transplantation. Already was evaluated at an initial stage where his oxalate was 28. When the reason for the oxalate evaluation was he had a history of a single left renal calculi, which actually spontaneously was expelled. And other than that, there was no other history of any renal calculi in his history or his family history. So with this oxalate level, it is a bit of a conundrum whether to do genetic workup for this patient or not. Panelists kindly advise me whether to proceed for transplantation with he wants his mother to be his donor. Would that be okay? Can I proceed or should I do a genetic testing? Thank you, sir.
Dr. Karthik, a single stone isn't an indication for a genetic testing. No, only one stone which is spontaneously passed isn't an indication for genetic testing. So that's how I see it. Only history of multiple stones, history of having nephrocalcinosis along with stones, that would be an indication. One single stone isn't an indication for doing genetic testing. We did look into one single stone in our institute as well, where we made a policy of looking all the stone disease for evaluating by genetic testing for hyperoxaluria, and we found none. I think we see about 60 plus cases and we found none.
Thank you.
Sir, this is Dr. Ravi. I have a child with nephrocalcinosis and genetic analysis suggestive of homozygous AGXT mutation, suggesting a type 1 primary hyperoxaluria, but he is having a normal renal function. And his 3-year-old child, the parents are very anxious and they wanted a liver transplant to prevent progression to renal failure. So can we offer a liver transplant for this child to avoid end-stage kidney disease for this?
Yeah.
I don't know whether I really question, I don't have a concrete, just like doing a pancreas transplant for somebody with type 1 diabetes. It's more complicated than that. So I'm very sure. So I don't know whether if somebody would do that, that kind of transplant.
I just go with 24 hours urinary oxalate excretion.
So he has some amount of oxalosis already happening in the kidney, I guess. Like he said that there is nephrocalcinosis.
It's there.
Yes,
I think. Okay, when the GF4 is more than 30 to 40, I think we offer liver transplant in this patient because he's only 3-year-old, right? Can progress to ESKD sometime later.
Okay, thank you.
It's also a question of ethics here, because offering liver transplant, putting somebody at a very young age to, immunosuppression. But then it's also contemplating a dual organ transplant versus stopping with a single organ transplant. So it's really, it's not a very clear-cut decision at any point. But it should be discussed with the parents. If they are opting for a preemptive liver transplant, then definitely say that you're going to subject the child to a more lifelong immunosuppression or cumulative lifelong immunosuppression. Versus in a combined liver kidney at a later stage of the kidneys are failing, the cumulative immunosuppression would be slightly lesser. So that versus having a dual organ transplant versus a single organ transplant. So it's never an easy decision to refer somebody for a preemptive liver transplant when everything seems to be fine. So in occasions, we have even referred patients and we have done for preemptive liver transplant, but it's a couple of cases last year we did do that, refer to a liver transplant center, but then it's always with explaining the risks and explaining the ethics behind it. So it's a tough decision to make, but we do that sometimes.
Yes. Thank you. Any more questions from the audience?
I have one more case. A 21-year-old girl was recently pregnant and lost her baby because of her hypertension and who developed end-stage renal disease immediately after the fetus expulsion, presented for renal transplantation, sir, with mother as a donor. Her biopsy done at the center was TMA, and she had thrombocytopenia at that time duration. So how to evaluate this lady, sir? Could it be a genetic which is precipitated because of the pregnancy, or it could be a pregnancy-induced HUS?
The same, I guess. So this patient is probably genetically predisposed and developed, HUS and ended up cortical necrosis. That is how I see it. So he's genetically predisposed. The pregnancy and plus the complications of pregnancy was the second hit in them. So that is how it. Most of the patients HUS need to hit one. Genetically, you'll find a family where only one person is having HUS, whereas all the others are also genetically predisposed. So the second hit is important. So here the pregnancy is the second hit, and you will have to see for, again, as I said, like you have to see for AH50 activity and C5B9. So if they are all fine, you can proceed with transplant. And it will be worthwhile to do genetic testing in the index patient and also in our mother. So you should realize, there could be a very chance that, the mother undergoes a surgery and if she's genetically predisposed, she could develop cortical necrosis. There is one report from Banaras University where this has happened. So you need to be a little careful. So, and you need to explain, as Sukanya says, you need to discuss the ethics. I think here also there is some ethics part. You need to discuss this in detail with the patient and their ethics.
Okay, thank you.
Thank you. Thank you then. I think we had extensive discussion and it's clear that we need more number of years with exposure to genetics to get clear-cut directions. I think we'll wait. Then before I finish, I wanted to ask Dr. Senthil and large institutions where they have a lot of data. This genetic, this Mendelian randomization, do you have enough, material or data to try this Mendelian randomization for any tests from our country? See, instead of RCTs, these days they recommend doing randomization by their genetic makeup. Dr. Senthil?
Yes, sir. Yes, sir. So, yes, sir. As in MedGenome, we have a very good reference database because as from the MedGenome, we recently participated in the large South Asian Cohort Consortium Human Genome Project. So, where we took individuals from the Indians, Pakistan, Bangladesh, more of South Asian cohort studies. It's more of not only for nephro related, but also for other indications for all the Mendelian inheritance genes. So we have the reference database, Indian ethnicity specific database is there, and we have a lot of nephro cases solved. So that Mendelian randomization is possible, and still we are adding cases to that database, sir. It is possible.
Yes, Senthil.
Yes, sir. So, for example, when it comes to transplantation, also this APOL1 gene risk alleles, they are identifying in always in the black ethnicity donors, African donors. So there is a ethnicity also matters when it comes to this mutation. Some mutations in,
1 minute, Dr. Raja is leaving. Yeah, before he goes, I got fascinated with this Mendelian randomization as an alternative to other RCTs. You foresee a time when most of the studies will be done on this basis? I think he has left. Yes, Dr. Senthil, you can. Dr. Senthil, your views? Is it going to replace?
That is a big comment. It's going to replace or not. What I'm trying to add here is that the database is evolving, and in MedGenome we have quite a good number of genetic data sets which would be helpful later on to do all the possible research activities. So that anyway we are gathering, and it is evolving, sir.
Okay, thank you. Thank you for all the panelists and the participants. I think we had very useful suggestions regarding the cases we presented today. And once again, let me thank everyone and say good night. I think we'll stop here. Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.